عايزين تقطيع.
Bismillah ar-Rahman ar-Rahim. Good morning, everybody. Thank you, chairpersons, dear professors and colleagues. I have no debate for tamoxifen, definitely in premenopausal, but I have some debates for postmenopausal. And definitely I have a critical shift to exemestane because first, the chemoprevention as a definition is defined as the use of natural, synthetic, or biochemical agents to reverse or suppress or even prevent carcinogenic process to neoplastic disease. And breast cancer chemoprevention has focused heavily on the endocrine intervention using the SERMs or the aromatase inhibitors recently. And these drugs are active in prevention of endocrine responsive lesions only and no effect in reducing the risk of estrogen-negative breast cancer. So we should remember some facts and considerations that had been mentioned by the National Breast Cancer Coalition that remembers that with chemopreventions, these drugs are given to healthy, asymptomatic women. Most of them will never get breast cancer anyway. And the potential risks and benefits in healthy women are a totally different story than those in women who take drugs for treatment. And this should be taken into consideration because this can influence the quality of life and hence the compliance. These are the Gail risk model where you can calculate the breast cancer risk for a lady. And this includes a long list as mentioned by Professor Hebaz-Zawahri, including the presence of atypical hyperplasia, the age at first menarche, the age of first birth, and even the number of biopsies taken, and you can calculate the risk. And if you have a 1.6% risk, which means that you can find 1 or 2 women out of 100 women, you can go for breast cancer prevention. However, the Gail have definitely not included many risk factors at the age of diagnosis for family members, the second-degree relatives, the lactation histories, the use of hormone replacement therapy, and the bone mineral density, and one of the most risk factor, the mammographic density, especially after the age of 35. These are the summary of the major breast cancer chemoprevention trials. Whether you use SERMs or whether you use aromatase inhibitors, we have 2 major studies for aromatase inhibitors, the MAP3, which uses the exemestane, and it leads to 65% prevention for all breast cancers with 75% for the ER-positive breast cancer, while the IBIS-2 use anastrozole, and it leads to 53% prevention for all breast cancer and 58% for the ER-positive breast cancer. The rationale of use of aromatase inhibitors in chemoprevention definitely come from the adjuvant trials where third-generation aromatase inhibitors has been found to be superior to tamoxifen and be able to reduce the incidence of contralateral breast cancers by a range of 37 to 55%. Not only that, these agents resulted in improved disease-free survival and are associated with fewer life-threatening side effects than the SERMs, making them definitely attractive agent for the use in breast cancer prevention. These are the first plots of the new primary breast cancer events in contralateral breast in the adjuvant trials of aromatase inhibitors, starting by the ABC, SG Arno, and the ETA, and the ATTACK, and the Big 198, and the MA17s, and all are in favor of using tamoxifen in the exemestane in the adjuvant trials. The IBIS-2 trials, they randomized the patients, approximately 3,864 postmenopausal women. They randomized between anastrozole and placebo. And the primary endpoint is the breast cancer incidence. Secondary endpoint is the ER-positive invasive breast cancer mortality, and the non-invasive or non-breast cancer deaths with some toxicity assessment, especially the cardiovascular fractures and other adverse events. And these are the baseline characteristics, which are well balanced between the 2 groups taking anastrozole and placebo concerning the age, the parity, the age at first menarche, the age of childbirth, and the number of biopsies, and even if you have a family history. And these are the results, the cumulative incidence for all breast cancers and of invasive ER-positive breast cancer, where if you give your patient a placebo, you definitely have a lesser breast cancer prevention than you give anastrozole. And as seen here in the figure, you have 5.6% versus 2.8% if you give anastrozole, and the 3.7%, which decreased to 1.4% when you use anastrozole. So definitely anastrozole can reduce the breast cancer prevention incidence of all breast cancers and the invasive ER-positive breast cancers. Also, not only that anastrozole can be used for breast cancer prevention, although it is off-label for the company. However, we have the side effects that we have some more fractures and musculoskeletal effects and arthralgias more with the anastrozole than the placebo group. So they conclude from the IBIS 2 trials that we have a substantial 53% reduction, provides convincing evidence for the effectiveness of anastrozole, and there is a small increase in the fracture, 8.5% versus 7.7%, which is not significant, and we have significant increase in the musculoskeletal adverse events with anastrozole, and the high rate also was seen with placebo, reaching up to 57.8%, unexpected reduction in other cancers, and provide strong support for the use of anastrozole in high-risk postmenopausal women, and long-term follow-up is essential to determine the full risk and benefit profile of anastrozole. And we came to the MAP3 breast cancer prevention trials, which use the steroids, exemestane versus observation. And again, this include 4,560 patients where they randomized postmenopausal high-risk women to exemestane at the usual dose, 25 milligram for 5 years versus placebo, 1 milligram for also 5 years. And as you see from the curve that yes, with exemestane we have less breast cancer incidence, and at a median follow-up of approximately 35 months, the annual incidence of invasive breast cancer was less in the exemestane group than the placebo group, and the ductal carcinoma in situ also is a statistically significant p-value, and both the invasive breast cancer and ductal carcinoma in situ are less with exemestane than the placebo. So where do the MAP3 data fit into the current knowledge of agents for breast cancer prevention? Yes, with 5-year intervention with SERMs, whether tamoxifen or raloxifen, as mentioned by Professor Zawahri, is associated with an approximately 40% reduction of invasive breast cancer at 10 years and more nowadays, 16 years by the San Antonio, last San Antonio. However, the MAP3 data suggests considerable greater efficacy with the AI exemestane for cancer prevention, with more 65% reduction in risk of invasive breast cancer and 73% reduction in risk of ER-positive breast cancer in high-risk women. So the global balance between benefits and toxicities generally supports the use of aromatase inhibitors over tamoxifen for breast cancer treatment and prevention in postmenopausal women. These are the potential risks and benefits, and all of us know that definitely with tamoxifen we have more hot flashes from embolism, endometrial cancer, and genitourinary adverse events, and with aromatase inhibitors we have more arthralgia, myalgia, and osteoporotic risk. However, there is no data on neurocognition, sexual function, or even cardiovascular disease nowadays. However, with preventive therapy, you have a lot of pitfalls and barriers. First, the lack of physician and patient awareness, fear of side effects and licensing and indemnity issues, and the optimal biologic dose remains a poorly investigated component of preventive therapy, usually imported from treatment trials. So future preventive trials of exemestane should explore more thoroughly the pharmacologic and pharmacodynamics effects of doses lower than the standard, which is 25 milligram per day, which is used in the MAP3 and in the treatment setting of postmenopausal women. And similarly, the schedule and duration of therapy remain unexplored, where long-term uninterrupted use may increase the toxicity in healthy individuals. Also, the lack of measurable biomarkers for efficacy, which exist for other diseases as cardiovascular disease, including the cholesterol level and the prevention of diabetes complications or even osteoporotic bone fractures, are lacking. Therefore, from person's point of view, they may take medication unnecessarily, or in the worst case scenario, unnecessarily suffered from the adverse events of such therapy. So they think that preventive therapy for cancer is often discounted as an over-treatment and used as an example of over-medication. However, the clinical use of biomarker in cancer prevention trials to select the early responders from the non-responders, we have just one trial from the IBIS-1, which used the tamoxifen versus placebo, as mentioned by Professor Zawahri, where the biomarker endpoint was a mammographic density. And they proved that 46% of the women who was treated with tamoxifen experienced more or less than 10% reduction in breast cancer density over 1 or 1.5 years, exhibiting a 63% reduction in the risk of breast cancer, which was statistically significant. And by contrast, women who take and experience less than 10% reduction in breast density exhibited no risk reduction. However, this point had been not explored even with aromatase inhibitors or even in the raloxifene studies. What about the BRCA1 and 2 mutations? Definitely it increased the risk of early breast cancer all over the age of even 40 years, 50 years, and even 70 years. We have the surgical options, which is risk-reducing salbentroephorectomy, which decreases ovarian and tubal cancers by 95%, and if premenopausal, 50% reduction in breast cancer, and the risk-reducing mastectomy decreases breast cancer by 95%. However, many reconstruction surgeries are needed. So chemoprevention in hereditary breast cancer, I agree with Professor Zawahri that we have a few data on the impact of chemopreventive agents, tamoxifen, raloxifene, and exemestane in women with hereditary predisposition for breast cancer. In the NSABP1, tamoxifen was associated with decreased incidence of contralateral breast cancer, specifically for BRCA1 carriers and BRCA2 mutations. However, in contrast to the NSAP, the STAR trial and the MAP3 did not address the effects of raloxifene and exemestane, respectively, in women with BRCA mutation. However, nowadays we have a randomized study between letrozole and a placebo in the chemopreventive setting of postmenopausal women in BRCA mutation, which was held by the French group. So my take-home message that MAP3 strongly supported the integrating the exemestane into the armamentarium of the breast cancer risk-reducing agents, and currently tamoxifen is the standard of care for premenopausal women, giving the lesser toxicity in this group, and based on the relative safety profiles observed in the STAR, raloxifene might be considered the standard in postmenopausal. However, the update of the STAR showed that the raloxifene retained only 76% of the effectiveness of tamoxifen for preventive invasive breast cancer, and they stated that raloxifene could be used to decrease the osteoporosis in postmenopausal women, and exemestane shows clear advantages in terms of efficacy and possible toxicity for use in this population. And the crucial issue at this juncture is to develop strategies for communication between community physicians and the high-risk women about the value of risk reduction of breast cancer and promoting a better understanding of the risk-benefit balance for each available preventive agent. And thank you very much for your attention.